Hello, my name is Tanzid Shams. I'm the Director of Neurology at Johnson City Medical Center. As a brain health specialist, I'm here to talk to you about utilization of MRI of the brain. One of the most rewarding aspects of working in ballot health is throughout this region, we work as a team and we rely on limited resources to take care of our patients. Often, we do not have access to subspecialty care, and it may be easy to reach for a diagnostic study in order to get an answer to a clinical question. The Value-Based Care Committee is a group of individuals, team members from the entire network, and we came together and we set some goals. Our mission is to practice patient-centered care, and our goal was to see, can we reduce the utilization of diagnostic studies in certain areas, namely in brain health, the MRI of the brain. Whether you're a nurse, nurse practitioner, physician assistant, an ER provider, ICU team member, a floor provider, a physician, one of the key things that we can look at and ask ourselves, are we practicing engaged patient-centered care? We can take a step back. Every time we're ordering a test, we can ask ourselves, how important is this test? How necessary is this test? And to what extent would this test impact the care for the patient? Every diagnostic test has a cost associated with it, and MRIs are not inexpensive. So it's important that we think about what diagnostic tests cost, because when we practice cost-conscious medicine, we're actually thinking about our patients. So I invite you to come along in this journey. We have set a goal of reducing the utilization of MRI by 10%. Our data analysts from Ballad Health analyzed the total number of MRIs that were ordered during the first half of 2018. Approximately 2,000 MRIs were ordered, and the indications included things such as urinary tract infection, sepsis, altered mental status, transient ischemic attack, stroke, and a plethora of other diagnoses. In the next segment of this video, I will go through each one of these indications and try to work with you to give you some pointers and tips, some questions you can ask yourself before an MRI of the brain is ordered. So come along in this journey with me to practice patient-centered, cost-conscientious medicine that does not overly rely on diagnostic studies. We take a pause to think about what tests are necessary and do best by our patients. For the second segment of this video, we're going to dig a little deeper and look at why some of the MRI of the brain are ordered. We'll look at it diagnosis by diagnosis and what questions you can ask yourself in order to minimize overutilization of tests. I'll give some pointers and questions you can ask yourself before the test is ordered. The first general area we can talk about is the infectious disease category and patients who come in with altered mental status. A tremendously large number of hospital admissions happen because patients come in with a change in their mental status. And commonly we see that these patients have an underlying infection. Sometimes it's a UTI, sometimes it's a pneumonia, and other times it's a patient who has become septic. In our data analysis, we find that a large number of MRI of the brain is being ordered for this category. If you take a pause in these patients where you're suspecting an infectious process, there is no real evidence-based or practice-based guideline for ordering an MRI of the brain. Let's look a little further into these scenarios. For instance, a patient with a UTI can have altered mental status. And the primary treatment really is screening for the UTI and treating with antibiotics. Similarly, pneumonia should be treated the same way. We don't always need an MRI of the brain to analyze patients' changes in mental status. Now, in this infectious category, what if this patient was even more critically ill? Think of a septic patient, where a patient has low blood pressure, high heart rate, and you're suspecting meningitis or the spread of infection to the brain. Even in those scenarios, there's really no strong indication of the MRI of the brain. There may be some enhancement of brain tissue in a diagnostic study, but the true diagnostics test in this case would be a lumbar puncture, which provides a lot higher yield. So once again, in this broad category of urinary tract infection, pneumonia, sepsis, infection, and altered mental status, there's a tremendous body of evidence that already tells us there's not necessarily a need to order an MRI of the brain. It would be prudent for us to pause and think about the primary condition we're dealing with and screening for a UTI, chest x-ray, lumbar puncture, blood culture. All of those diagnostic tests are available before an MRI brain could be ordered to investigate an infectious process. Let's talk a little bit more about altered mental status patients. Now, it's a big category. A lot of patients come through our hospital system with altered mental status, and the underlying etiology is not always infectious. There's a long list of causes for which patients' mental status can be altered other than infection. They include medication overdose, electrolyte abnormalities, hypoxic state, dementia, and many other causes. And once again, if you think about the non-infectious causes of altered mental status, an MRI brain is still not the primary diagnostic study in these conditions. In summary, when we looked at our analysis of 2,000 cases from the first six months of this year, altered mental status was one of the top reasons why MRI brain was ordered. This is my invitation to you to take a pause. When you're dealing with a patient with a change in their mental status, MRI of the brain is not necessarily the primary diagnostic study. Another common reason we see an MRI brain ordered is for headache. Now, this is a very broad category, and people come into our hospital system with headache for many reasons. So let's go through some of the common scenarios. One of the other causes we commonly see MRI of the brain ordered is for headaches. Hundreds of patients come through our health system with a complaint of headache. But there are some general conditions such as migraine, chronic tension headache, hypertension, for which people experience headache. It's always prudent to take a pause and think about the underlying cause of headache. There's really no indication to order an MRI of the brain for individuals who have a history of migraine or chronic tension headache or even hypertension. It's better to take a closer look at their medication profile and take a pause to ask yourself whether an MRI of the brain is really necessary. On the other hand, here's a helpful tip that can help you whether to actually go forward with ordering an MRI of the brain. As a neurologist, I find it helpful if we find a focal sign and symptom that goes along with the headache. For instance, if a patient provides a history of diplopia or slurred speech, because the number one reason why an MRI would be helpful is if we're really trying to capture a mass lesion in the brain. And hardly ever a mass lesion comes with just headache. If somebody has a tumor or cancer in their brain, there are other neurological signs and symptoms that are present. They include nausea and vomiting, sometimes in the morning, eye movement problems, slurred speech, memory difficulty, word finding difficulty, along with the headache. So once again, take a pause when you're dealing with a patient with headache and try to take a look at the pattern of the headache, the medications that they're on, their vital signs, and it would be helpful for us to make a distinction between the patients with migraine, hypertension, chronic tension headache versus something more critical. In the next segment, let's talk about stroke and transient ischemic attack. In this segment, I will actually present a very counterintuitive concept to you. The largest number of MRI brain was actually ordered for our stroke patients. And it may seem counterintuitive to you, but an MRI of the brain is actually not always necessary to evaluate a stroke patient. And here is why. When a patient has a large territory stroke in their brain and they're presenting with facial weakness, arm weakness, leg weakness, where the symptoms are very apparent, we can use our clinical exam to localize where the stroke may be. In other words, if you have a patient with a total body hemiparesis, putting together with other clinical information, it can often be very apparent the patient has a stroke. But an MRI of the brain is not always necessary in this case. The indications for MRI of the brain in stroke cases are more subtle. When you're suspecting a cerebellar stroke, when there's a much smaller stroke that is not always clear from your clinical presentation. The patient may have scattered embolic stroke from having chronic atrial fibrillation. So once again, when a patient is presenting with a clear, large, whole body symptoms, evidence of large hemispheric stroke, an MRI of the brain is not always necessary. So the main take-home point in this case is that for large strokes, MRI of the brain is not always necessary. Now, in contrast, let's consider cases of transient ischemic attack, or TIAs. TIAs are more subtle. Typically, most patients with transient ischemic attack or TIA symptoms, they resolve within the first 24 hours, and often within the first few minutes or hours of presenting with some focal neurological symptoms. So initially in this video, I said that this concept may be counterintuitive, but an MRI of the brain is actually more helpful in TIA cases, and here's why. A patient may have history of atrial fibrillation and embolic stroke, which may have given them a focal neurological sign or symptom. Because the symptoms have resolved, a detailed imaging of the brain is more illuminating and more informative for us. Thus, in cases where we are admitting patients and evaluating patients for TIA, MRI of the brain can be more helpful. Another common condition for which we often see an MRI brain ordered is syncope. It's important to keep in mind that 90% of the syncope cases are actually caused due to cardiovascular etiology. Here are some of the common things to keep in mind. Things that cause syncope include low ejection fraction, hypotension, or even orthostatic hypotension, which is due to changes in a patient's position. Sometimes they happen due to age-related autonomic dysfunction. When we group together all of these causes for syncope, very few of them are primarily related to brain function. So it's not always necessary to order an MRI brain on patients who've come in with syncope. We should always take a pause to investigate the other underlying etiologies that are more common, namely the cardiovascular system, before we order an MRI brain for syncope. So thank you on behalf of Ballad Health. We've set a very modest goal of reducing MRI brain utilization by 10%. Next time you're in front of a patient with headache or syncope or altered mental status, take a pause and ask yourself, is an MRI brain really necessary to practice the most patient-centered care, cost-conscientious care? Thank you for coming along in this journey with me. I believe we can achieve this goal of reducing utilization of MRI of the brain.